All right, we're going to have a session on the approach, the prep and the approach to nasal intubations. The prep that I use involves the 2% lidocaine gel that comes in this plastic cartridge, with a glass cartridge in the plastic tube. Screw it in. There's only 100 milligrams of lidocaine, so you don't have to worry about overdosing your patient. I put the entire amount into any kind of container. A styrofoam cup works perfectly well. The next component I use is the Afrin spray. I just turn it upside down, put in a couple of full squirts. It's next to impossible to overdose a patient on Afrin. I do not use neosynephrine because there are reports of patients getting hypertension and going into heart failure, acute heart failure, from the neosynephrine spray that we used to have. That stuff is extremely concentrated to the point that it's 10 milligrams per cc, and obviously it's pretty easy to give 1 cc into this container. What I then do is I mix this up into a kind of a slurry that is about the consistency of maple syrup. It's thinner than the lidocaine gel, and you can kind of see how it kind of drips off very slowly. The reason I want that kind of consistency is it sticks around for a little bit on the patient's nose, or inside the patient's nose, and it allows for a bit of spread over time. And how I start with the patient is I have 2 sets of the 4-inch Q-tips, but for this demonstration I'm only going to use 1. You start in, you have your slurry, you have both full, and you just bring it into the nose, and you just start with a swab around the rim of the nares, little bit at a time. Get a little bit more, and you just go in a little bit deeper with each prep. Little bit more prep. Then usually I stop about right there, have a conversation with the patient, tell them they're doing great. Sometimes they need to be a little sedated. Most of the times you can get by with just talking to them comfortably. Now, as you probably know, all the awake nasals involve a discussion with the patient, and you do require some cooperation from the patient. After I hold it there for about 30 seconds, you get a little bit more stuff, and you keep going further back, and I just kind of do a little circle motion, and then I just kind of leave it in place. The extra liquid that is on the 2 Q-tips has an opportunity to bathe the nasal passages so that you're in a position to continue to numb even though you're just holding it right here. Ultimately, we just keep putting a little bit more in, and we just go a little further back each time. I'm shortening what appears to be the prep procedure. This normally takes between 3 and 4 minutes to get a decent prep in somebody's nares. This is going to look like it's around 2 minutes on this video. Ultimately, you're going to keep putting in more prep until you can get these Q-tips all the way to there. Once you have made it that far into someone's nares, you are now with a relatively to completely numb passage all the way to the posterior pharynx. Once again, I use both sides so that if something goes wrong with the first side, the tube doesn't go through, something doesn't go right, I can always move to the other side. So you will always see me prepping both nares. Every now and then I come across a patient where you can tell almost immediately you can't get through the turbinates on one side, in which case then I'll concentrate on the other side. But almost without exception, I prep both nares, both nostrils, all the way down until both sets of Q-tips can go this far in without the patient jumping off the bed. The reason I like this approach ties in with how I go about doing the nasal intubation. So the prep goes aside. Okay, so now we move over and we start. You will have done this before you started your nasal prep, but we're going to view how you have your scope set up before you intubate the patient. For ease of equipment purposes, so we're only using one scope, I've got a pediatric scope loaded with a 7.0 tube. You will see that the tube is taped all the way up, and you'll find out why I prep just the nose and why I do it this way shortly. The other thing I do is I take a 10 cc syringe. If you want to get a slip tip syringe. Now what a slip tip syringe has is it does not have the screw in part to hook into a stopcock or anything of the sort. So if you can't get your hands on a slip tip syringe, if you take a regular syringe, and I've already cut this a little bit, and take scissors and gently go through, this pops off. You can cut this, the screw top off, and now you have a slip tip syringe. I usually take around 2 or 3 cc's of the 5% topical lidocaine. Put it in, set this aside. I usually put about an equal amount of liquid and air into my syringe. You flip this over, and now your slip tip syringe is into this part of the scope. This suction adapter fits in here. You have to kind of push it until you feel it snap. You can either hook suction to this or oxygen to this. I personally don't start with either until I decide whether I need suction or oxygen to help. If I do use oxygen, I only use it at 2 liters a minute so that the jet doesn't distort my anatomy. And now I'm proceeding to intubate nasally, intubate the patient. Remember, we've already prepped the nares. We're heading in, and once you get to this view where you have your epiglottis and your vocal cords in view, that's when I go in and I push in my lidocaine and the lidocaine through this. You must be careful as to not activate your suction if you are using suction, because then the lidocaine you inject will actually go out your suction catheter as opposed to the patient. I'm not going to do this here to make a mess, but ultimately we'll take this out and just, you can see that it just squirts out on the side. And as simple and stupid as it sounds, the reason I put the air in, you then clear out all the lidocaine from your scope. So back to here. I usually give them around 30 to 60 seconds to make sure that my lidocaine has a chance. I do warn the patient that they might cough with this. So now you will see that I'm getting ready to instrument the vocal cords. Broken as they are. Tube goes in. That thing up there is the plug for the dummy. And now I'm well past the cricoid cartilage. There you can see in the dummy anywhere, the carina. And now when you pan back to the patient's face, you will notice that the tube is not in the nares. I like this approach because I have not stirred up any bleeding. I have not burned any bridges. When I go to insert the endotracheal tube, I then push both in. You can't do it easily with the dummy, and I'm not going to do any damage to the dummy. But you push both in, and then with the tip of the scope at the carina, untape this and advance it the rest of the way. And now you can confirm above the carina placement with your scope, and now your patient is intubated nasally. Let's see how that looks.